Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, as usual. And today I brought one of my previous mentors and attending back in residency, Dr. Stephen Boos, to discuss with us the very important field of child abuse. As clinicians or physicians in the pediatric emergency department, child abuse is unfortunately something that we inevitably come across, sometimes more often than others, and it is something that should sit on our list of I never want to miss it. Dr. Boos has been a child abuse physician for many years. I thought it would be great to have him on the show so he can share with us his wisdom. Thank you, Dr. Boos, very, very much for coming on the show. I really appreciate it. I think the PEM Rules listeners will greatly benefit from your experience and your wisdom. Let me just introduce you to the listeners. So Dr. Boos received his medical degree from Columbia University, graduating in 1983. He then completed his pediatric residency in 1986 at David Grant USAF Medical Center. After residency, Dr. Boos took great interest in the field of child abuse as a general pediatrician for 12 years, and then he completed a fellowship in child abuse in 2000 from the University of California. And since then, please correct me if I'm wrong, Dr. Boos, this is what you've been doing with all your time. Is that correct?
Much of my time, I like to do a little things on the side. It's an interesting thing to spend all your time doing, and I like to see and help kids in other ways as well. But okay. I've certainly been doing this ever since 98 as the great majority of my professional activity.
Very nice. From a personal standpoint, I can say that Dr. Boos was my attending in residency because I did my residency at Bay State Children's Hospital where he was an attending. And I don't know if Dr. Boos remembers, but he actually interviewed me when I was a medical student applying for the residency. And I distinctly remember my child abuse or child advocacy month at Bay State. I learned a lot of information from Dr. Boos, and having gone for a PEM fellowship, it has served me very well. So welcome, Dr. Boos. Thank you very, very much for coming on the show. How are you?
I'm doing well. It's good to be here, Yaron.
Thank you very much. My first question to you, Dr. Boos, and it's a question that I ask all my guests. Every guest has a sort of a different perspective based on what they do for a living or the subspecialty that they're in. But my first question to you is, what is your ideal PEM doctor? One who does what?
Yeah, so there's a tendency to answer in threes, and I will do that.
Okay.
The first thing I'm asking out of a PEM doctor is to have a high sensitivity to presentations of potential child abuse. In the world of physical abuse, there's data for a variety of presentations of child abuse where children have been seen previously about a third of the time, and someone has evaluated them either for an injury or for a symptom, and appears to have missed the opportunity to identify child abuse. So we were talking earlier, you were reflecting on some head injury PICU deaths that you were involved in recently. If you look back in those cases, it's not at all unusual to see that someone saw the child for a bruise or a minor injury, or the child came in for vomiting in the absence of fever and diarrhea, and nobody really picked up on it. And we believe that picking up on those when it leads to a child abuse diagnosis can lead to prevention. And perhaps even when it doesn't lead to a child abuse diagnosis, it's enough of a warning to the family, enough of a shake-up in the family that perhaps future abuse events can be avoided. So that high degree of sensitivity is the first thing I'll put on my list. Okay. You can get there using clinical prediction rules. We like to talk about 10-4 faces P. I mean, I can remember it easily, but it's kind of a long acronym. It stands for bruises of the torso, bruises of the ear, bruises on the neck, 4, meaning 4 months or under, any bruises in young children, and I would even generalize that to 6. It's not as nice an acronym, but I think it's reasonable to do so. The F then is for frenular tears. We have some arguments about that because it's not unusual for kids to fall against a coffee table and lacerate their upper labial frenulum. But there is good data, isolated data on frenum tears to say that it is worth at least the question. And certainly if it's under the tongue or the lower lip, then maybe it's worth a total evaluation. The angle of the jaw, the cheek, the fleshy cheek more than over the zygoma, the eyelid, and then subconjunctival hemorrhages. Again, this is an area where we sometimes get pushback because kids are vomiting or coughing or screaming their heads off, and they can get subconjunctival hemorrhages. And we know that, but if you look at the data, subconjunctival hemorrhages have been studied as themselves, as opposed to as part of 10-4 Faces P, and the data is supportive. In the original study conducted out of Chicago, but using multiple centers, the positive predictive value of 10-4 Faces P was 63%, which is pretty darn impressive. I would say there's other rules of thumb. If you see a kid with a fracture and they're not ambulating, you got to evaluate it.
Sure.
There's been a meta-analysis to suggest that you should be evaluating all kids with femur or humerus fractures under 18 months and all children with rib fractures under 3 years. A more complicated situation works out with the clinical prediction rule, the Pittsburgh Infant Brain Injury Score, which looks at children in their first year, I believe it is, who present in the ER with things like irritability but no fever, vomiting but no diarrhea or fever, somnolence that is unexplained. And then there's a rule that looks at age, head circumference, bruising, and then the CBC. And that rule is fairly good at predicting who is going to have an occult head injury if you choose to image them. And then finally, I put in this rule, 2 and down in a gown. We like to talk about the top to toe examination, because if they come in for a little bit of irritability and you don't see that there's a bruise on their belly, you may just rack it up to something else. Whereas once you see that bruise on the belly, 10-4 Faces P kicks in, and you really need to think about child abuse as a possibility. The second thing on my list is I think we really need to be intentional about questions of equity. There's clear data that BIPOC people, Black, Indigenous, people of color, that these populations are over-assessed for child abuse at every level, that we generate suspicion more frequently, that we generate reports more frequently, that we substantiate reports at the CPS level more frequently, and that they go into foster care more frequently. Some of this is because these people are also the people who are incredibly stressed by economic situations and built environment and the structural racism in society, and that these stresses may cause them to be in worse situations that underpin child abuse. But some of this is just plain old bias. And so I think we have to be cognizant of this as we proceed. I like to look at screening instruments. There's been a series of screening instruments studied in the ER. Many of them have expectations that physicians will assess the interaction between people or people's behavior. I'm always a little worried about that, because when someone looks like me, feels like me, I feel comfortable and I'm less judgmental. Whereas if someone comes in with funny hair, funny tattoos, too many piercings, who knows what other biases I might kick in there, I'm already a little bit uncomfortable, and I think I'm more prone to be judgmental of their behavior. So I worry about that. But this issue of bias comes in even in sneaky little ways. So a colleague in Kansas City did a study using simulation, and he would have an actress with a doll baby come in. The clinician would get a preload of this is what happened at another facility. This child is now referred to you in your ER, and then would pick up from there. And they would take their own history. So everybody got the same history on the preload. The actress delivered the same history. When the actress was Black, it was more likely that the physician would assess a unreasonable change in the history, even though that was totally controlled. Now, we don't think of changing histories as being something subject to bias. It sounds relatively objective. And yet, this one contextual factor, the skin color and race of the actress, changed it, even though the histories were the same. And then my third thing, I think, is doubly important because of what my first thing was. And that is, I'm looking for a certain amount of humility and compassion. If you're going to do what I asked first of you, which is to be extremely sensitive, to pick up things early, to do the right kind of questioning and additional studies, you're going to be doing studies and asking questions and filing reports on people who are innocent. You cannot get that high sensitivity without a certain sacrifice in specificity. And so these people deserve your compassion, your understanding, a certain degree of forbearance in their behavior, and to be treated well, because some of them are going to come through at the other end and be found innocent. And because even those that are guilty are usually guilty because they're living lives that you would not want to live yourself. And I think that deserves your compassion.
Very good. Those are excellent advice and really, really good points. Thank you for those, Dr. Bruce. My other question to you, or my next question to you is, as a PEM physician or PEM clinician, I always think about child abuse in the back of my mind, and it's something that sits on my list of, I never want to miss it. So kind of like appendicitis for abdominal pain or Steven Johnson syndrome for a kid that comes in with a rash. It's on my list of, I never want to miss it. What advice do you have for us PEM physicians or PEM clinicians to tease out those cases out of our very busy workflow? As you know, child abuse cases are our exception, not the rule. Most kids with head injury are not child abuse. Most kids with bruises are not child abuse. So it's kind of easy to miss. What advice would you give us so we can tease out those cases from our very busy workflow?
So I thought about this before, and I certainly recognize that the pediatric emergency room is a super high volume place. So you're constantly going through patients, many of whom probably don't belong there, but either don't have a good care system or don't know how to engage that care system in a better way.
Sure.
Mixed amongst those patients, then, are these patients with incredible high acuity where you've got to take action because you're saving someone's life. You are genuinely saving someone's life in the moment with what you do. And so I know you have to live in this world of type 1 thinking. It's like recognize, act, recognize, act, recognize, act. That's the way you survive, and that's the way your patients survive. So I would say that developing really good guidelines is really a priority for child abuse. I developed a guideline for our ER, and our guideline is divided into two large chunks. The first chunk is, if you see this, that is the entry point to this guideline. A lot of guidelines presume you already know what you're working on, and that just guides you through that. This defines what the guideline is intended to apply to, and it is drawn out based on age and the nature of injury. And I'm not asking people to make judgments of the people before them, although I'm also not saying you should ignore something. I mean, if someone is obviously behaving oddly, or the interaction is obviously challenging between a parent and a child, you're going to respond to that. And sometimes that's going to be the guide that gets you. But mostly, I'm just looking at the epidemiology of injuries. 10-4 faces P, fractures in non-ambulatory kids, certain fractures in kids who are ambulatory, any head injury from a private event, falling out of bed, something like that, burns that occur in bathtubs, things of that sort. The guideline that I do for Bay State, that chart also appears slightly differently, but it appears in my up-to-date chapter on recognizing child abuse. So your listeners can look it up there and then adapt it, because it merits adaptation. This is my view, and I think it's got good literature basis. That's the whole premise of up-to-date. But we're always making value judgments about where we want to set the threshold, right? So I think having good guidelines works for physical abuse. The problem with a guideline is you got to remember to read the guideline, which means that until you've got that inkling of suspicion, you don't know to go to look to see if the guideline says you should have that inkling of suspicion. And so if we're going to have these guidelines, we're going to have to train people to them, and we're going to have to periodically retrain. Okay? Things drift in your mind. You've applied it once, you learn to do something one way, even if the literature hasn't changed. If you look 6 months later, you're probably doing it subtly different, and you probably need to go renew. Plus the idea that things do change. Now, it has been made automatic for some people using computer-assisted clinical decision support. There are these systems developing out there. Again, the people in Pittsburgh were big leaders in the development of this, and they are promoting and extending their services, their systems. But other people have developed some of these things as well. I think we will see them roll out. The early data is that they don't over-alarm too much, because we're always worried about alarm fatigue, but they will sit in the background, either working on your notes, if you've got natural language processing as part of your record, or your little check boxes, or a screener done at intake by your nurses, and they will prompt you, hey, think about this. And if they're done well, they will also direct you to an order set that guides you through an appropriate assessment. So I think for physical abuse, guidelines, training, periodic retraining, and then as we move forward in this IT venture we're all suffering through, computer-assisted clinical decision support. Sexual abuse, the regular old sexual abuse that we've been talking about since the 80s or so, usually walks in with someone saying, I think someone sexually abused my child. Okay? It declares itself, and then you just got to figure out what to do. But there's new attention being paid in the last 5 years or so to child trafficking, or what we call commercial sexually exploited children. These are harder. There are instruments that are coming up. If you look for the work of Dr. Jordan Greenbaum out of Atlanta, that'll connect you to a lot of it. She's developed some of the clinical screening tools. But if a child is coming in with runaway behavior, you should be thinking about this. And if they're carrying something of value, or they're wearing new clothes, or they have a new cell phone, and they're coming in from runaway, you really got to worry. If children are coming in with sexual transmitted infections or pregnancy scares as a repeated thing, you really got to be thinking about what we call CSEC, commercially sexually exploited children. If they're coming in with an adult who is not their traditional guardian, you also need to be worried. And then if that person won't leave or won't let them talk or is controlling the environment, you definitely need to worry. So these are just some of the things that might tip you off to a C-sex circumstance. There are others. If you want to get one of those screeners and use it, you have to figure out when, because you're not going to do all teens that way. But they have been studied in ERs, and particularly in ERs when people come in with sexual complaints. So I think those are the things that I could think of to try and keep you right on the edge without falling off of it. I'm sure other people might have other ideas as well.
No, those are, again, excellent tips and really, really good information for us, those clinicians who sit in the ER and see high volume and, like you said, sometimes very high acuity, so we don't lose any cases of child abuse and child trafficking. So those are really, really great advice. I know, Dr. Booz, that there was one more thing you wanted to discuss with regards to COVID and what it has done to the field of child abuse or to the field of medicine in general. I'd love to hear what you have to say about that.
Yeah, so it's not so much what it brought forth to the field of child abuse. There is that too, but that's more of a prevention talk. But more what it's brought forth to the field of medicine. Um, Many of the people listening to your podcast and those that they work with have been struggling with the consequences of going through COVID. It was really hard on people. And there's been a lot of people leaving the field and a lot of people dealing with behavioral health consequences of their COVID experience. And I think while there was already some talk about burnout in medicine, I think that COVID made this talk into a huge agenda, a huge agenda. And I think that child abuse medicine is another area that when you're dealing with, as we were saying before, multiple deaths in the PICU from abusive head trauma injuries in 1 week, this is really hard stuff to swallow. You know, I trained in the era before the H flu vaccine, and we saw meningitis after uveitis, after epiglottitis, after septic arthritis, and all of these children, were sick as could be, and they had a single-celled organism that was the source of all their problems. I can accept that. That's traditional medicine. As one ID doctor put it to me, it's about pus and now shots, right? This is different. We're seeing kids whose lives are being impacted and changed by someone who should be taking care of them. What sort of an emotional challenge is that to a person who chose to take care of people for their living? And then to make it even more complicated, if we're maintaining that high sensitivity, we're evaluating and will be perceived as accusing people who ultimately turn out innocent. Now, we're pediatricians. We're in this caring dance with parents. That's what we do day in, day out. And all of a sudden, we're in the position of worrying whether our usual partner is actually the cause of the problem. And then having to do something about it where we know we might be accusing or at least evaluating, but feels like accusation on the other side, someone who would normally be our partner in care for this child. So I think these things are very emotionally challenging. It's easy to get numb. And if you get numb, you could either lose your sensitivity, the first thing I asked of you, or you could lose your humanity, which is the third thing I asked of you, right? Is to be compassionate. And so self-care, I think, has got to be a critical element of all physicians' practices. And I would even put forward, because there's a tendency in the world of vicarious trauma and burnout to put self-care first. We put a lot of responsibility on individuals for taking care of their own burnout and vicarious trauma. And that's not really fair. The data would suggest that just making everyone responsible for their own care is an ineffective way to maximize the benefit, and that institutions and leadership really need to proactively think about that.
Very well said, Dr. Bruce. Thank you very much for saying that and recognizing the stress that all physicians, but specifically for child abuse, PEM physicians are under. And that kind of goes back to one of the rules I speak about with my residents is you got to take care of yourself before you take care of others. Because if you don't take care of yourself, that's going to affect how you take care of others. And I agree with you. I also like to hear how, as a leader in your field, you take care of your team. So I think that's also very, very important. Thank you, Dr. Bruce, very much for coming on the show. I think the information you provided is major helpful for the PEM Rules listeners. And I think we all can benefit from your wisdom. So I really thank you for dedicating some time from your busy schedule and coming to talk to us. I already told you, Dr. Bruce, I have a little tradition in the podcast where I try to play the outro of the choice by the person who was a guest. And I guess you like the band Yes and wanted to hear Mood for a Day. Is that right?
That's correct.
All right. So I'm not making any promises because I'm not that talented, but I do know the band Yes. I'm going to listen to Mood for a Day and hopefully we'll get an outro just for you.
Thanks, Jerome.
Thank you very much again. Thank you for coming on the show and appreciate your help. And that is it for today, guys. Thank you very much for listening and thank you for tuning in to PEM Rules. Please continue, check out my website and sign up for the newsletter. I promise there'll be more content in the future. Please also write to me if you want to come on the show. If you have an interesting patient or apply the rules in any sort of way, let me know and I'll love to have you. The following outro is Just Like Dr. Bruce Asked, a song by the band Yes. I could not do Mood for a Day. That's a little bit beyond my skill and capabilities. But here's a classic Yes song, Owner of a Lonely Heart. Hope you like it. Thank you very much.